and welcome to the next session on stage one. It's my great pleasure to introduce Ian, who's a product specialist from Better. You're going to talk to us, Ian, about the low-code modernisation of EHRs. Over to you. Thanks very much.
Thanks, Shane. Hi, everyone. So, yeah, I'm Ian Bennett. I'm a product specialist at Better, and Shane said I'm going to be talking about low-code tooling and how it's used in combination with an open data platform approach to modernise the user experience for clinicians that utilise clinical systems such as electronic health records. So starting with what low-code actually is, it's tooling really that enables you to create applications where you don't require a background or knowledge of software engineering or development. So effectively, it's applications that are created by the end users that are going to be utilising that solution themselves. Across these types of solutions, these low-code toolings, they tend to have certain features that are common across those type of platforms. So visual interfaces, so being able to use visual interfaces to create your application rather than written code. And this is typically shown through interfaces such as drag and drop functionality. So this could be buttons that you bind data to. It could be predefined functionality such as a save button and date and time components. And those are effectively just dragged and dropped, these reusable components, onto a blank canvas. And one of the key benefits is that it really promotes fast release, so you can deploy it straight to a production live system that clinicians can get active with and start using straight away. You just hit the publish button, so there's no upgrade process or lengthy time for it to start being used. And it enables agile, quick, iterative development as well, because the visual forms allow you to change things dynamically there and then. So it's also really great for improving clinician engagement into the process. So a very simple graphic to sort of show the difference between typical coding and low coding. What you've got on the right there is what would be termed as an integrated development environment, something like Visual Studio, which developers typically use to put their written code in to create an application. Whereas on the left-hand side, you can see with low code, it's something much more visual to create the application that end users are going to interact with. And the users that tend to create these applications through low code are typically being coined as citizen developers. That's a term coined by Gartner, who are an industry leader when it comes to research and insight into digital trends. And they describe citizen developers as end users who create new business apps for consumption by themselves and others using development and runtime environments sanctioned by the IT. And effectively what we're seeing is that the driver for this is that as business needs change, organizations must be able to deliver innovation quickly and dynamically respond to changes required to applications as well. And we're going to see a continuous rise with these citizen developers. So Gartner also predicts that by 2023, the number of active citizen developers at large enterprises will be at least 4 times the number of professional developers for the creation of applications, and accelerating further through to 2025, whereby 70% of new applications developed by enterprises will use these low-code and no-code technologies. So why does this specifically apply to healthcare, and why is it of interest with healthcare? So there's dissatisfaction with the usability of mission-critical systems in healthcare when compared to other industries, and that's measured against the targets for usability across software. And a poor usability and bad user experience with something that a healthcare professional is using can actually be interpreted as a clinical risk. And there's lots of evidence to support this, including from the Mayo Clinic, where clinicians evaluate the current systems for usability, gave it a grade of F in terms of how they felt they were using it, and that was evaluated against, again, standard metrics for understanding usability of software. And physician burnout was also linked and correlated to the usability of these EHR systems. And what we don't want to do is add to the burden of these clinicians with these healthcare applications when it should be actually reducing the burden for them. And CLAS, who are a research organization, do a lot of industry leading research into the usability of EHRs, and especially in the acute care market. They saw that the satisfaction rate for the acute EHR market is lower than the software average for over 5 years. So we commonly see that the usability of EHR systems, the systems that clinicians use day in, day out, is lower than when compared it to other industries and their mission critical systems. And Gartner again provided some focused advice relating to healthcare, whereby they said inflexible IT portfolios limit innovation and agility, and the monolithic large EHRs that we have impede the digital transformation, being able to respond in an agile and quick manner to growing changes. On the right-hand side, that's another usability study. This one was done taken from a study done in the UK on EHRs used in the emergency department. And basically, no UK emergency department electronic health record system meant the internationally validated standard of acceptable usability for information technology. And what we're commonly seeing is that this backlog of requirements relating to applications being able to respond dynamically to changes is going to increase more and more, and just generally the number of IT development skills to surface that need is not going to be sufficient, which is why we feel that some of this gap is going to have to be plugged through these citizen developers that use low-code tools. Okay, so when we talk about what good does look like, or which is something that NHSX has a certain mantra around in terms of continuous improvement, class talks about some key tenets of what makes a good EHR. So it's about personalization, so personalized for clinical use for those clinicians, shared ownership, so they feel that they can have the ability to feed back into how that EHR is used, and then those requests are then acted upon, and they see that dynamic change coming about in their end use of the application, rather than long lead times to actually realize change of a system. And there's only limited amount of value you can get from configuring and manipulating an existing system. And they want to feel like expert users, so they want to be able to feel that they can get the most out of the system, that they can train others on it, and that also comes with it having something that's intuitive to use, which is part of the usability of an EHR. And we'll probably find out more about this as there's ongoing surveys across all care sectors at the moment being provisioned by NHSX around national EPR usability surveys. So we'll find out more about what makes a good EHR experience and what doesn't. And linking into this is some pieces about the component structure and architecture of these electronic health record systems. So within an article published in Forbes, it said that EHR is dead, long live the EHR platform. And that links to a policy draft white paper that was published by the Department of Health and Social Care, whereby we're starting to look at separating the data layer and the application layer. So the presentation layer to clinicians, they can use something that's personalized for use for them, meets their clinical needs, and those changes can be made more dynamically by having an architecture that separates out the components where you store the data and being able to respond flexibly with the clinical front end. And again, low code plays directly into that. Okay, so this is a graphic in terms of why low code for healthcare and why we see it's important to deliver low code in combination with an open data platform approach, rather than just using a low code tool like picking up Power Apps from Microsoft. It's important that there's some healthcare specificity to low code. So on the left-hand side, you can see an approach which uses building blocks based on the OpenEHR specification, which we use at Better to structure the clinical data, and architecture from the bottom upwards, really. So you have structured clinical models, and then you can use the low-code tools to build out applications using those low-code tools, using those building blocks, and you can build out different applications. So you can build the version of the application on the left, or you can build it on the right, so different presentation layers, and then you can then dynamically shift between the different presentation layers, so dynamically change the application front-end view for those that are going to be using the system. Compare that onto the right-hand side where you've got these monolithic EHR systems where they haven't got that separation of the data layer, where they have proprietary data models that are unique to them. They haven't architected it from the ground upwards, and we're now sort of looking at basically trying to pull information out of these legacy systems using standards such as FHIR. But effectively, to make that change from the chicken application, or whatever you want to call it, the chicken front end, to something new, we require a feature request to that provider, to that organization and vendor supplier, and then they would have to prioritize that into a backlog. So there's not a lot of ownership by the organization in making rapid and impactful and dynamic changes. And this is a graphic of how we do things at Better with our low-code approach. Is again, starting from the bottom up, really. So thinking about a vendor-neutral data core, so not a proprietary data model, rather a shared community of clinically curated data models that we then use to build out structured clinical data models. And then you can use low-code tools to rapidly build out and assemble applications. And that can then those applications then can be surfaced in multiple different areas. So they can be surfaced in existing EHR systems because it's all web-based solutions, or it can be surfaced in something like a portal, which we also have at Better. So we see this being used in multiple different ways. So to add into the existing ecosystem of applications that are out there in clinical use, but also for net new applications where there's a new requirement and a new way to surface those views. So again, it's the same type of model, but looking at the actual screens that enable it. So on the left, we have some open source technology called Archetype Designer, which is developed by Better, but is used by the whole open EHR community who create these clinical models. And the idea is that clinicians and clinical informaticians create these clinical models using the Archetype Designer. Once you have those clinical models, you then can make use of them within the low-code studio, okay, and create out your applications using those clinical models to create a coherent understanding of the information against what you're building, rather than getting that spaghetti type underneath foundations. And then that can be surfaced, as I mentioned, within something, for instance, like our portal or another solution to show that information. So it can act as an adjunct to existing systems to provide an enabler to improve innovation and enable dynamic change where you may be limited by existing vendors' capability to do that. So effectively, it can work alongside in the beginning, and we see it's potentially being used more and more for the mainstream clinical systems as we go forward as well. So who's interested in this type of approach? So we've signed a contract with the Christie's NHS Foundation Trust. They're a specialist tertiary cancer centre, the largest single-site cancer centre in Europe. And they currently have over 600 clinical forms that they use to support care delivery within their clinical portal at the moment. And effectively, they're going to repurpose those using Better's digital health platform. So they'll replace it with that approach of having a vendor-neutral data model underneath, and then use the low-code tools to build out the forms. And they're going to use this opportunity to enable some redesign in clinical pathways as well, so that they can really focus on how they maximize the patient journey from referral through to the end of the pathway. And what they'll get from this is an optimized and personalized experience for the clinicians, a consistent user experience with the design, the consistent design approach with the low-code tools that we have. And again, that vendor-neutral longitudinal care record. So the idea being that if they choose in 10 years' time, or whatever it may be, that they don't like our low-code platform, that data is not bound to our application, so they could plug in a different application to start using that data that they've built up, because it's not specific to a vendor in terms of owning that data. We've also deployed these forms at Somerset NHS Foundation Trust, so the nursing risk assessment forms. So there's an example of a diabetes foot screen assessment there. These are all done by the bedside on iPads using the tooling, so using the forms that have been created using the low-code tooling. and again, based on those structured clinical data models. As an example of the sort of rapid approach to being able to create these forms, during the COVID pandemic, they created assessment forms through a rapid clinical co-design and deployment process to surface caption of information in the acute care setting within 2.5 weeks from inception to published use and it being used on the ground. Oh, sorry. And then last is that we don't see this confined to one single setting. So we're working with Suffolk and North East Essex integrated care system across that whole region. So we did a successful proof of concept around end-of-life care planning, so capturing patients' wishes at end of life and enabling access across both all care settings really, so from clinicians, but also involving the patient in that process. And again, this going through a process of iterative co-design of care plans with clinicians and patients to build out those forms. And the visual way of doing this through low code, again, accelerates that process and accelerates pushing that through to production and use. And working against a single source of truth. So, as mentioned, coherent, structured clinical data models underneath to actually work against that data so that everyone's updating a single source of data, including the patient within this example. Okay, so this is a quick demo of the sort of nuts to soup, I guess, or effectively using what we've got here is the Clinical Knowledge Manager, and this is a repository of publicly available, clinically curated, what are called archetypes, but clinical data, and we can export that to a repository, so that Archetype Designer that I referenced, and then we can import that publicly available clinical model into our repository and upload it. And then we can actually move that into what's known as a template, which then forms the basis of our clinical model to use in the low-code tools. So this is effectively creating that clinical model, which then provides the foundations for what you're going to create your application on top of. So what you can actually do is constrain and extend these data models. So as an example here, I say, oh, maybe I don't want to use confusion as part of the data model. This actual clinical use case for this is assessing the severity of a patient's pneumonia so that the treatment pathway can be decided based on how severe their symptoms are, based on how they're presenting. So we can then export that into the EHR Studio, into the form builder, application builder solution. And we start with a blank canvas, okay? And on the left-hand side, we've got those reusable components that I referenced. But the first thing we're going to do is bring that template so that we can start using that coherent data model to start creating our form. So one of the first reusable components that we use is this rich text one. So just to entitle the form, to call it Curve 65 form. And then we can bold that information and we can do some slight alterations to it. And then what we're actually going to do is start using the information from the template. So you saw that we created a structured clinical data template, and we can start dragging and dropping this information onto the screen. And it's all against a common, what we'd call information model. So you've got different types of data that have been created in the clinical model. So some of it is scored information. So you can see you get a different score based on whether it's a yes or a no. And some of it's free text information. And some of it is just an actual actual scale of score as well. And we can actually link this to then like SNOMED coded information as well. So we're actually clinically coding the information using standards such as SNOMED. We've just done some slight alterations there to the size of the screen, and then we're going to import an image. So we're just going to use the giant logo here, then decrease its size. And then basically if I go to preview, effectively we've got a very, very basic, but something that could function as a form, but it's got no real logic behind it. But effectively within the preview screen, you can see that you can populate that data, but it's not very good with the fact that we aren't using any logic to populate the total score or the severity. So what we're going to do now is add some interactions and dependencies. So add a bit of beautification by adding some spacing with one of the reusable components, and then we're going to add some. This is why it's called low code, because you can still use elements of scripting. So we're going to use some HTML text to add some information and make it look mildly pretty with a pink background to show some information as to why this tool is used and why the clinician is using this impact assessment tool. So it's not showing very good resolution, but that is a pink background. And then we're going to add another image here which shows a treatment pathway guidance. So we're going to take some guidance from the British Medical Journal. Again, we can move that over, we can reduce the size, and then we can effectively, then what we can do is have some logic to say, do we want to display that or not? So by default, a clinician might not want to see this clogging up their screen every time. So we're going to have some logic in there to say, show that guidance and toggle it on or off. So we're going to move that to a toggle switch, and then we're going to do some quick, what we call dependencies or interactions, to basically say when that is ticked, show the image, and when it's not ticked, hide the image. So we can build these on the fly, and these are very similar to, we have an expression assistant which helps you to build these out, but it's very simple if logic to effectively say, hide it in this case, otherwise show it, or vice versa. Okay, and then what we can then do is preview our form again, and we can see some of those changes. So constantly, you can see this is the agile design approach, whereby we can make a change, see how it works, see what it looks like for the front end user, and we can toggle that information on and off. So just to make some other changes, the last piece is now to do these interactions between the actual data you're capturing and the scores against the form itself. So I just moved that spacer just for, again, some more improvement of the layout. But then what we can actually start to do is put some logic against this score. So what we can say is when basically this field is populated and all the other fields are populated, then calculate a total score for this patient's risk. And that will then help determine the next phase of treatment and how severe their pneumonia is. So we just write out this logic, and again, we have an expression assistant. So if you can do Excel functions, then you can basically write these different types of logics. So if you want to do things like make something, put the date format in a certain way, then you can call that from an external API and then modify the data. These are very simple dependencies, but as I say, what you can do is actually call data from external APIs as well, bind that to the data, and then display that. But obviously, even with just 10 minutes, there's only so much we can show you. And this is an example of the expression assistant building out the dependency. And then just the last piece here is that we can also then make that read-only. So you can hide things, which I clicked by mistake, but you can make that read-only so that it's not available for a clinician to change that or someone to change that once they've put in the relevant information. So here you can see it calculates the information and adds up the score. So the very last piece is just to then take that score and bind that to a severity. Okay, so we want to say that if it's if the patient has a score of 2, then it's a medium severity. If it's 1 or less, it's low severity. If it's more than 3, it's high severity. So effectively, again, we use these interactions, and we say when the total score is greater than or equal to 3, then it's a high severity, and then the same will do for the other fields. I should have slightly sped this up, sorry, because it's just going through. Slightly can be a bit repetitive, but effectively what you can see, which can be quite interesting for you, is that it binds it to an internal OpenEHR code. So what that moderate severity is then structured data in the OpenEHR specification. So when you set it to a code here, it has an internal reference that it can link back to. And then effectively what you can then do is utilize that information across different applications and forms, because it's all against that coherent open data model. So just the last one, and the reason that I'm just not speeding this on too much is because I just want to show you how the actual design then can be tailored to different formats. So you can show how it looks on an iPad, you can see how it looks on a mobile device, you can see how it looks on a desktop, and all of that's in the preview. What I'm not going to show you here is actually publishing the form, but it's as simple as clicking the publish button there, and that can go straight into production. Okay, so just to finish off with this demonstration. So what you can see now is we've still got all our functionality. We can do the calculation, and when it's total score of 4, the chair is hiding it, but it does say high severity, and we change it to 0 to 1, and it says low severity. And then we can see what it looks like on a tablet device, which they're using in Somerset, and then we can see it on a mobile device. So very last thing to say is that I showed you a simple form there, but what we'll see is more and more advanced capabilities being brought into these low-code tools, and that's effectively with what our next drop of functionality is starting to build on this with what we're calling widgets, which is effectively different visualizations of the data. So create visualizations and then bind the data to it. And you can start to create these dynamic views of the data for the clinicians and personalize that using this low-code approach. Thank you.
Do you want to take some questions for a few minutes?
Yeah, sure.
Because we started a little bit late, so we've got a few minutes for questions if anybody'd like to. Ian, I just firstly like to say, as somebody who's worked in the electronic patient record space for 25 years, and I know Thomas, Thomas, your founder. I think, great, and I think you're putting this into the hands of clinicians or anybody, make it really easy so they don't have to keep coming back to suppliers with a lot of expense and time to create these forms. What I really love about it is the national open or international open libraries that people can take things forward from. That's a great transfer of knowledge, really well done. Would anybody like to question or comment on what they've seen today? Yep.
Hi there, thanks for that. My name's Sam, I work as a GP down in Lewisham, and I'm sure you're familiar with QoF and all these targets and things that we've got to meet, and just seeing you putting in those creating that form so nicely, just made me think of all the sort of hellish tick boxing exercises we have to do for a pretty straightforward task, which really isn't that clinically challenging. And I was wondering if just what is the integration like? I know you touched on it, but I just want to know more in a practical sense. If I had a ton of iPads in my waiting room and I got my patients just to fill in their demographic, their smoking history on some forms that I'd made that were important to me and after surgery, how could I then integrate that into their records?
Yeah, so we are actually doing some work to integrate with, I don't know if you use EMIS or TPP, one of those systems. So initially with the care plan work, we'll be taking the forms and surfacing them as a contextual launch through from the EMIS and TPP systems. There is some limitations that we're finding at the moment in that integration with the GP systems can be confined to doing some contextual launch. But with time, effectively that approach will move on to that example you used there, where effectively you've got the form being used as a standalone solution on an iPad, capturing information, and then we can pass that information back as SNOMED coded information, which can then link to a QoF point. So that is the plan for what we're doing across regions with end-of-life care planning already. Just at the moment, we're doing it through direct launch from the EMIS and TPP systems themselves, but you will hopefully see some easing in the burden of the idea of automatically populating information such as SNOMED codes to then get recognized QoF points.
Hi, I'm Maddie from Eva Health Technologies, and we're trying to create a new electronic medical record to rival EMIS and TPP, so keep an eye on that one. I love this. This is brilliant, and this is where the world is going, but it also requires people to have an understanding of clinical safety and to have those assurance processes to sign it off. So are you also, as a company, trying to build and extend out the sort of a community of people who understand not just low, no code, but also the assurance and clinical safety that is required for the context in which we operate?
Yeah, so it's a great question, because as you start to put dependencies into it, then it starts to move into, as you say, medical device territory. So we have taken some of our solutions, such as the meds product through, such as some of the calculators there through the medical device certification process. In terms of creating that wider community, I think what we're seeing that is with those that are using the low-code tools actually looking towards this in terms of creating a community themselves, and that's on the back of that open EHR community. So as more and more regions take this idea of structuring the data in a certain way and using that format, and then using low-code tools to build out the applications. There's more of a community that's being created around other issues such as clinical safety, and that also ties in with the fact that everything that's done with the building of the application has clinical design at the heart of it. So it's very much front and center, but I think we've not gone through the process of getting everything certified as a medical device yet.
70% of the data that we hold on people is coded and typically limited in systems, but that only represents 30% of the data actually about the patient. Is there any plans to allow free text and using natural language processing that you can code from that?
So if it is free text information, then you can still get at it within the open EHR specification and query it quite simply to pull it out. In terms of natural language processing, we're sort of looking at that within almost like an innovation hub experiment at the moment. So we've done some work with that, and we're also looking at doing it with taking a paper form, scan that in, and then map that to OpenEHR Archetype. So almost like optical character recognition on steroids. So it is something that we are looking at, and the other piece that we're looking at is with and working and speaking to NHSX a little bit about is getting structured information for medication data. So working as a GP, you'll know that the medication information for dose and instructions is less structured than what makes it ideal for analytics purposes. So it is something that we're looking at, but nothing that we're going to take to deployment anytime soon.
Anybody else? We're going to leave it there then. Oh, one more.
Yeah, so I'm a medical student at Manchester. I'm actually founding the Manchester Medical Coding Society. I'm just wondering, what are the sort of limitations of low code? At what point are you going to need to bring in a dedicated programmer, dedicated software engineer?
Yeah, that's a great question. Probably also how it distinguishes from no code is that, at some point, we do enable that there is still scripting available as part of this, so that, if you do get really stuck, then, push it back to us as something that we can add in. But you can add some JavaScript code into it to sort of do some really, really complex logic. But yeah, you're right, there are limitations, and that's why we need to add more and more things like those widgets and visualizations to start being able to create a visualization of the data in different ways. So I see it as like a natural progression, but in the meantime, there's stuff you can do with scripting to supplement it.
Ian, thank you very much. It's been a brilliant presentation. Thank you, audience. Thanks for your participation. We're going to break there for lunch. And just to say, come back in an hour and a half to stage one at 2:30 till 3. We've got Saeed, who's the Digital and Business Transformation Senior Director at Janssen, and also at Sensign Health at 3 o'clock with Martin Goldstein, who'll be talking about their work. But thank you very much for joining us this morning. Hope you've enjoying the conference. And thanks again, Ian.